I will be talking and restricting my talk to conventional management pearls. The section about the other aspects will be covered by the later speakers. Essentially, this is how we talk about the current dry eye therapies. Tear supplementation is a very large chunk. Tear retention, tear stimulation, biological substitutes, anti-inflammatory therapy, essential fatty acids, and environmental strategies. This is broadly the way in which my talk is going to go. And the only point where I would like to, why this picture is here is, away from what conventional books show us, the 3-layer tear film concept, we have moved away from it, and we now realize that the tear film is actually an emulsion or a mixture, wherein these layers mingle with each other, the lipids being in a higher concentration outside, but it is not as if that they stop at some magical micron number and then the water starts. There are a number of polar lipids which will flow in towards the components in the aqueous area, and similarly mucins will be more towards the base, but they will also be present inside the aqueous segment of the tear film. Now essentially this is something which I would like to say, because as clinicians we get inputs from various quarters, and many a times we either are unable or we do not bother to check or cross-check the information that is made available to us. So it is difficult to prove that any ingredient is an active agent. So that is the basic line which I would say is the take-home message in the opening of my talk rather than coming at the end of my talk. Almost all the tear supplementation that we talk about is a palliation, it is not curative. So what is the aim? The aim of any lubricant essentially is, of course, to lubricate the interpalpebral area, replace the missing tear constituents, reduce the elevated tear film osmolarity, dilute or wash out the tear inflammatory or the inflammation inducing agents, but also we must remember that they can wash out the essential substances which the tear film is producing for its own defense or for the defense of the ocular surface. So it is not as if a lubricant every minute is going to be superior to a lubricant put twice a day or 4 times a day. And this brings us back to that question which came up. Any treatment in dry eye, I believe, and we call it as a symptom-based therapy rather than a sign-based therapy. So if a patient is happy putting his drops 2 times a day, so be it. I do not insist on any patient that you have to follow my prescription. If in my intelligence I have written it 1 hourly, it doesn't mean anything as far as he is concerned or she is concerned. The patient should feel comfortable. That is the bottom line of any treatment. An ideal artificial lubricant would be preservative free. It should have potassium, bicarbonate and other electrolytes. It has to have a polymeric system essentially to increase the retention time, and it should be hypotonic or isotonic buffered solution to achieve a good relief in the situation of a dry eye. A little bit touching up on the preservatives, because I think this is the most maligned part of ophthalmic preparations. All of us are almost now convinced that preservative equals to bad. No, not necessary. I'll just come into it in a moment. Benzalkonium chloride is present in most of the preparations. If it is a mild dry eye with a 4 to 6 time usage or a moderate eye with a high number of usage, then the risk of toxicity goes up. So what is the meaning which comes through from all this? Is toxicity of a product is related to the concentration of the preservative, but more importantly, it is required to be understood what is the frequency with which we are going to be using it, or what is the level of tear secretion inherent in the eye for which we are going to use that solution. And of course, what is the severity of the associated disease pattern and what other drops are going to be going into that eye. So the summary of this would be, if a patient with grade 1 dry eye and who is going to be using it only say occasionally and going to be using it for a few days or a few weeks, a benzalkonium preserved drop may do the trick at a much lower cost as compared to going in for the more expensive versions, though you need to be able to segregate it and say that for the patients who have a moderate or severe dry eye, things may be different. So you need to analyze the situation of a patient yourself and not randomly say that, okay, all back is bad. There are other preservatives which have been used. EDTA is used more to augment other preservatives rather than a single preservative by itself. Sodium chloride and sodium perborate are the ones which are now in fashion and are most used. They are, according to me, mislabeled. All the drops containing these two preservatives are mislabeled as being preservative free. They are not preservative free. They contain sodium chloride and they contain sodium perborate. That they behave differently when they fall onto the eye is a separate issue. Will this be fantastic for eyes which are in severe dry eye situation? The jury is out on this because obviously there isn't enough research material available. I think that will come when we find some new preservative which we will say that is better than sodium chloride and perborate. So then we'll start saying that those two are also useless. Ointments and gels are some other versions which are available. I'm just using it to do the completion of our discussion. Most of them contain mineral oil and petrolatum or lanolin. Usually these do not need preservatives. Gels with carbomers, which are acrylic acid based substances, are also available now. The advantage these have over mineral oil and petrolatum is that they have better retention times, and in today's busy days it is more important that they cause less visual blurring as compared to the mineral oil based situations. We always have this whole jig of, my solution contains X electrolytes and his contains Y, and we have a X plus 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 kind of a combination and they have X minus minus minus. The bottom line of all research is that potassium and bicarbonate, these are the two most important electrolytes which should be present in any given formulation. Rest of them do have a role, but they are subsidiary to the presence of the bicarbonate ion in the preparation. That's the reason why I've highlighted this over here. Touching upon osmolarity, there are two elements to osmolarity that needs to be understood. Crystallite osmolarity is ion dependent. Colloidal osmolality is macromolecular content of the surface tears. And this crystalloid osmolarity is higher than normal in dry eyes, and this is what is pro-inflammatory in nature. So this is what triggers off that cycle of what we now know as inflammatory dry eyes. And this leads to alteration in the corneal and conjunctival epithelia. The macromolecular content related oncotic pressure is involved in water transport into the tissue, and this brings us to the concept of osmoprotection, which I'm not going to go into the details because my next speaker will pick it up. Solutes, which are like carnitine, glycerin and erythritol, etc., are also now incorporated in many formulations because that is supposed to provide osmoprotection and therefore maintain the health of the surface cells in the ocular surface. Now, various agents are present. A question which gets often asked is, in a given situation, which one would you use? So whether CMC or whether HPMC or whether sodium hyaluronate or whatever. With due respect to everybody in this room, my personal problem is that I don't know which one to use. Practically speaking, this has been the one which has been around for quite some time. It has been the CMC and HPMC combo, the polyvinyl alcohol based drops. Now polyethylene glycol and glycol 400 based drops are also available, and sodium hyaluronate drops are also available. Each one will claim his or her superiority over various others for various factors. What I would say is that each one of them probably has a role in a very, very selected subsection of dry eyes. So if you're going to try and do that, then the kind of practice you have would be almost exclusive dry eye practice. For a general ophthalmic practice, whether any one of these has a specific role or a superiority over the other, I think again that question remains unanswered, at least to my mind. The problem with the other thing is that there are viscosity issues. In the sense, you will have 0.3% drops, 0.5% drops, 1% drops. It is important to understand that more viscous means more retention, but it also means higher caking and flaking on the eyelids. So patients who we give very high viscosity drops may not always be the most satisfied or happy patients. In fact, they may end up being the most unhappy patients. Castor oil and HP Gore, these two are also now making their way into some formulations, but both of them do not have a US FDA element of approval, though that to me does not mean that it is an unusable thing. It just means that it has not been studied enough. And the funny thing is that the FDA monograph contains all these elements which were used as food additives and not really as a sanction for using in eye drops. The only difference between hyaluronate and the others is that it has a long residence time. So the frequency of drops which would be required in moderate dry eyes could go down significantly if it is used. Anionic, the carboxymethyl cellulose, usually lasts longer than the neutral HPMC, and this tends to protect the surface epithelium and coats it, and therefore it helps restore the protective effects of mucins. So in that sense, an anionic molecule would be useful or more useful in patients where you see a significant ocular surface epithelium disorder. And what does all this mean? So all the jargon which I use essentially means that it has to improve the symptoms and probably the objective findings, but there is no evidence that one agent is superior to the other. If you go back now and think of all the data which has been presented to you, you will realize that most of these studies conveniently compare themselves only to something which is known to be inferior to it. There is no head-to-head trial between multiple agents in the same group. And that obviously tells us that nobody knows which A or B is superior to C, or is it that just all of them function reasonably well in most situations. The second segment is tear retention. The reason I am bringing this up is that tear retention can be done temporarily or permanently by occluding the lacrimal puncta. The reason I am bringing this up is it is quite being promoted now as being a very simple and an easy solution to tear dry eyes. Just put the plug and forget about it. Patient doesn't need to do anything. It's not as usual. It is not as simple as that. As we all understand, inflammatory dry eye. So that means inflammation is a significant problem in many dry eyes. When you plug the eye, you have taken away the drain, which means that the pro-inflammatory cytokines
Vinay,
or the inflammatory materials...
We need to rush it a little bit.
Sure, okay.
Thanks.
Would need to be looked at. So therefore, there should be no ocular surface inflammation. Only then can you consider putting in a plug. And downside, as I said, is this. Moist chamber goggles are very simple, but may not be cosmetically appealing. However, patients who have moderate to severe dry eyes benefit very significantly with this one single method. Silicone rubber contact lenses or scleral lenses with or without fenestrations are also successful in helping these patients because they help retain the film under the lens surface. Secretagogues, several investigated, but pilocarpine oral and now rebamipide, which is a mucin secretagogue, has been available in our country. It helps by increasing mucin-like substances and hydroxyl scavenging effects on the UVB-induced epithelial damage. Serum drops are there. This is something which I would strictly say that should be reserved by a cornea specialist in his or her practice. It has several downsides in terms of how it is made, how it is used, how it should be controlled. So trying to use it very freely in a general ophthalmic practice may not be a very good idea. Anti-inflammatory therapy, all of us are aware, tetracyclines have been around for quite some time, and they have these three properties for which they are used in the ocular surface problems. Steroids, of course, are there, cyclosporin, and now tacrolimus are also available. Omega-3 fatty acids, they do help in the meibomian component, and they would therefore indirectly or directly change the dry eye presentation. And this is, broadly speaking, the Japanese Film Society suggests this kind of an approach. It's there for all of us to see. So which lubricating would I use? As I said, take your pick and be my guest. Environmental strategies, you need to look at this. This is not in the core area of my discussion because some other speakers will pick this up. And thank you for your attention, ladies and gentlemen.